So any questions from last time? Everyone feel pretty comfortable with the material so far? Hopefully we will see. This first section's wrapping up pretty quick. I was like, man, my test is coming up soon. Kind of exciting, right? It's next Friday, something like that. Is that right? Okay, yeah, that'll be good. In the week, right? Hopefully. Anywho, so we're going to finish up this last section. We're talking about action potentials. Remember, we're talking about different ways that ions and different substances can move across that biological membrane. Action potentials are very, very important, as I mentioned, for both things like neuronal communication, talking about cardiac conduction. All these things are going to be very important concepts here. This is the basic action potential, and the way this works is essentially that we mentioned that all of our cells have this resting membrane potential, right? And it's usually positive or negative. Usually going to be negative, usually between like -70 and -90 sort of is where it's going to be resting at. Because remember, the inside of the cell is more negative than the outside of the cell. And so that's why I had that negative resting membrane potential. And so normally what's going to happen, and this can either be triggered by, say, for instance, a neurotransmitter, or say an action potential is traveling along the neuron or whatever cell it happens to be, you're going to see these action potential occur. And so the first thing that normally happens here is you're going to have these sodium channels that start to open up, right? And so these sodium channels open, in which direction do you think sodium is going to flow? Out of the cell, into the cell? Yeah, it's going to flow into the cell, right? Because we've mentioned that the sodium content is much higher on the outside of the cell than it is on the inside of the cell. So when you open up those channels, again, this is a passive process. This is just going to be a transport channel that's opening up when it gets that signal that's going to allow for sodium to flow in. And so what do you think that's going to do to the electric potential of that cell? So positives are flowing in, become more positive. Absolutely, yes. Yeah. So this is why you see this big depolarization that occurs here, allowing all these sodium channels to open up, all the sodium flows in, and so now the balance is shifting to where the inside of the cell is actually going to be more positive than what you would see on the outside of the cell. Okay, called the depolarization that occurs there. Now, do those sodium channels just stay open forever? No, that wouldn't be good, because then we couldn't really reset the cell at all. So at some point, those are going to close off. You can kind of see that right here as the sodium cells close. At this point, you have to have a process called repolarization, and this is going to try to get us back to our baseline, essentially, so that the cell can have another action potential occur here, right? And so basically what happens here is the potassium channel is open, and potassium is going to flow in which direction? Again, this is a passive process here. Remember the salt wrap banana analogy? Yep. It's going to flow out of the cell, right? So again, now we have positive cations that are flowing out of the cell, again, along its concentration gradient. And so you're going to notice it's going to have this dip back down, and actually may have what we call a hyperpolarization, where it actually becomes more negative than it would be at its resting membrane potential. But that's okay, because now what we're going to end up having is our sodium-potassium ATPase pump, right? And so remember the sodium-potassium pump, what is that doing for us? So is it pumping things along concentration gradient, against the concentration? Remember, that's against the concentration gradient. So it's sending sodium out of the cell and sending potassium into the cell, right? So again, this is a critical protein, because this actually helps us to reset and get back to our resting membrane potential. So you will see that you'll have that hyperpolarization. Those potassium channels will then close, right? So now we've kind of eliminated that flow of potassium out of the cell, and then the sodium-potassium pump can then get things back down to your resting membrane potential. And now the cell is reset, and it will allow for it to have another action potential to come along later on, right? And again, do you think you can trigger like another action potential right in the middle of this period here? You can. Anyone know what that term for that is? All or nothing, sure, that could be one thing to refer, but in the fact that you cannot have another action potential until you've kind of reset this whole process. Perfect. Yeah, the refractory period is what we're going to call that. And so that's going to be a very important concept when we get into cardiology, because that refractory period is what allows our heart to beat in a very organized sort of manner. And if you have refractory periods either get shortened or lengthened more than they should be, that's when arrhythmias can pop up. And so that's another important concept to remember, is that refractory period, to where you cannot have another action potential until things have sort of reset. Okay. But remember, sodium is going to be in those channels, when they open up, that allows sodium to flow in. You have a big increase in your electric potential there. You know, potassium channels then open up, it's going to allow potassium to flow out of the cell. That will cause the repolarization, and then sodium-potassium pump keeps the things at resting membrane potential. Okay, make sense? Any questions on that? So again, this will come up again and again in neurology. It's going to come up in cardiology. Those are the two big places we're going to see that most frequently. Okay. So any questions on the first half, or I guess that first section we covered yesterday? Fantastic. Now we're going to move into talking about endocrine stuff. Everyone should be having some good endocrine function happening right now. You had a nice leisurely lunch. You know, you have some insulin flowing, but now you're in class again, so maybe your cortisol is going to start ramping up, and now you're stressed out again. So we're going to talk about all these different things and how they have different effects on your body. So, and this is super important because when any of these things go wrong, lots of diseases can occur from this. And so these are usually some of the first things you're going to be trying to assess in your patients when they're coming to you for a complaint, whether it be an infection or whether it be, you know, fatigue or pain or things like that. A lot of these can have an influence on that. So it's important to be able to assess these and determining if is anything wrong here, or can we do anything to fix that. So again, our endocrine glands, how do these differ from exocrine glands? Anyone know the difference? Yeah, so endocrine glands are going to be secreting things into the bloodstream, so things are staying internal or endocrine, versus things like exocrine glands would be secreting things outward, right? So, and that included the GI tract. So, for instance, like the pancreas can be both an endocrine gland and an exocrine gland, right? So that's one of those things we'll see a little bit later on, especially when we get into the GI section a little bit later. Anyway, so again, hormones are basically like the body's drugs, essentially. They can go through and via the bloodstream, they can either inhibit, they can stimulate, they do all sorts of different things within the body. Now, do hormones only act on, like, say, one type of tissue? Typically, no, they're pretty wide-ranging in response in some cases. Some of them are going to be more specific than others. Some might only interact with one type of tissue. Some of them can affect all different types of tissue. And we'll show you some examples of that as we go along. But these are very important because they help to maintain homeostasis, for one thing. They help to regulate things like metabolism, growth, reproduction. They have all sorts of effects here. So we're going to cover kind of the major endocrine organs and then what sort of hormones are going to be running into most frequently here. Okay, so just some other ones. And again, how is a lot of this going to be regulated? I already see you guys have started talking about this probably in like an anatomy or something. Negative feedback loops are going to be important. What are the key components of that negative feedback loop? Has ever heard of the HPA axis? The hypothalamic-pituitary axis. A lot of these are going to be regulated via that HPA axis. And so this is important as well because when you have patients who, say, for instance, have like a tumor, they have to have their pituitary gland resected. That causes all sorts of problems. In fact, I remember when I was in pharmacy school, when I was interning, or not interning, we were volunteering at this Florida School for the Deaf and Blind. As we'll learn about vision in the next section coming up, we're going to see a lot of that, all that kind of that tissue is all right in the same area between the hypothalamus, the optic nerve, and all these different things. And a lot of these kids had tumors that caused their vision to go. That when they got removed, they also caused their pituitary gland to be interrupted there. And so all their hormone systems were completely off. They had to have a lot of these things kind of given exogenously in order to help kind of keep their growth hormone in check, make sure their reproductive hormones were in check, all these different things because of how important this axis is. And if you screw up this or mess with it, you can have all kinds of different disease states occur here. So again, the hypothalamus, the pituitary, and then the kind of the effector organs out in the body are going to be the kind of the main things we're going to be referencing here. And we mentioned the negative feedback loop, so we're going to see that all the hormones that get secreted at any step in the process have the ability to feed back and can influence whether things get, increase in secretion or decreases in secretion, as we'll see in just a little bit. So here are the major glands we're going to talk about. We'll talk about these in detail as we go forward. So again, this you can kind of reference back to this. These are the main ones we're going to be talking about today. Okay, so looking at hormones. Hormone interactions, usually you're going to find that hormones are going to be somewhat specific for certain tissues, but some of them can be pretty wide-ranging. So, for instance, cortisol can have an effect on nearly every organ system in the body, whereas things like, for instance, like FSH and LH tend to be very specific for, say, like the reproductive organs. And so some of them are going to have varying degrees of specificity, which we'll talk about moving forward here. But just know that they can either be antagonistic, which what do you think that means, based on what we covered in pharm? Yeah, they kind of go work against something or they inhibit something. They can be synergistic. What does that mean? They help something work better than it would with either one by itself, or in some cases it could be permissive. I don't know what that would mean. They what? Yeah, they kind of allow something to happen, or they may sensitize the tissue to allow for a different hormone to become more effective, essentially. It's kind of like synergism, but a little different there. And we're going to see that based on the different influences here, based on how much of an antagonist is present versus an agonist versus some of these permissive things, can influence how big of a response you're going to get. And we'll go over examples of this. So, synergistic, as we mentioned, is going to be when two hormones are going to be working together to produce a particular effect, and you're going to get more response out of both of them together than either component by itself, essentially. So, a good example of this would be with lactation, right? And so, it's going to be one of those things where you're going to see that oxytocin and prolactin are going to be two big hormones that are they're responsible for one, milk production, and then also for that milk letdown that allows for a response to that signal of a baby suckling or a baby crying or something like that. That kind of kicks off that whole process, right? So again, like when mom hears that the baby's crying, that can start to kick off this whole process. We're going to have milk production being stimulated by prolactin, with the oxytocin actually causing the actual milk letdown so the baby can get some food, essentially, right? And again, that negative feedback loop is going to be when the baby stops suckling or the baby stops crying. Guess what? Then they may actually stop that whole process there, right? So that's one example where two hormones are working synergistically in tandem to make sure that that baby gets fed, essentially. Permissive effects, again, is going to when one hormone makes another one more responsive. And so a good example of this would be during, let's say, the female menstrual cycle, when you're going to end up seeing that the early rise in estrogen, again, you can see in the day period here, because the normal menstrual cycle is how long? 28 days, right? So you're going to see that early on, this increase in estrogen actually makes the tissue more responsive when progesterone comes along and actually surges later on in the cycle there, right? So that would be one example. We have a kind of a permissive sort of effect here. Another good example would be something like parathyroid hormone, which gets abbreviated as PTH, actually makes the intestine more responsive to vitamin D3, which itself is working as a hormone. Vitamin D3 tends to have a positive effect on increasing intestinal calcium absorption, which is why, where do you normally find vitamin D? What sort of food do you see it added to? It has a lot of calcium. Milk, yeah, right. That's why I put vitamin D fortified milk, so that way you can have this interacting and helping to facilitate better calcium absorption. PTH can actually help to make those intestines even more responsive to that. So it's kind of a permissive sort of effect there. And then antagonistic effects, the best example of this is going to be insulin and glucagon. If you have low blood sugar, what gets stimulated? Glucagon gets stimulated in low blood sugar situations to start gluconeogenesis in the liver. It's going to raise blood sugar, and then what comes along in response to high blood sugar? Insulin, right? That drives in, glucose into the cells. And so again, those are very much a kind of a seesaw sort of effect there. Again, they're antagonistic to one another, right? All right. Now, we talked about half-life. Anyone know what a half-life is? Besides a really good video game?
The amount of time it takes for something to disappear, 50%.
Yeah, so basically the time it takes for 50% of a substance to be metabolized and eliminated, essentially. This is very a critical thing we'll talk about in pharm, for sure. Everything has a half-life in the body, essentially, right? Some things have a very long half-life that can be months, years. Some things have very short half-lives that can be seconds long, essentially, right? And so basically it's just the time it takes for a substance to decrease by 50%. Just like you're thinking like a radioisotope or something, like, the half-life of like uranium is whatever, how many years. Same thing applies here, just how long it takes for 50% to be gone. And again, you can find that certain things are going to have very long half-lives. Things like, thyroid hormone tends to have a long half-life and takes a long time for big changes to occur. Other things are going to be a lot shorter, and you can see much more immediate changes more quickly, right? And then typically when the hormones are secreted into the blood, eventually they're all going to end up in the liver, and we'll see that the liver is one of the main sites of metabolism in the body. You normally will break those hormones down into less reactive products, and then can eliminate them usually either the kidneys or through the bile, things like that. Okay, so again, looking at hormone concentrations, typically the body is going to have a certain normal level, and again, quote unquote normal. We're going to see that obviously some people can fall outside of that and still be considered, they're normal. But when you find that levels either get too high or too low, that's when disease occurs, essentially, right? So again, if I don't have enough thyroid hormone, I have hypothyroidism, right? Exactly. So again, just an example of that. Now, for instance, when you have very high levels, you may actually find that some of these hormones actually lose some of that specificity, and they can actually interact with other receptors they might not normally would at a normal physiologic concentration. So, for instance, you have progesterone. Progesterone can cause things like menageria or breast tenderness, right? Normally, you wouldn't think of progesterone having a big effect on the breast tissue. However, at very high concentrations, you can see that they start to lose that specificity, may interact with things like estrogen receptors, right? So again, you don't have to know that example specifically, just know that high concentrations, you lose specificity, and they can interact with receptors that look kind of similar, but not maybe 100% like what they normally interact with. Make sense? We mentioned upregulation and downregulation before. This is, again, just a reiteration of this point that when you have high concentrations of a hormone that's around, your body doesn't like to have that, right? Because the body likes to maintain homeostasis. So in response to high levels of a hormone that's around, you can either do things like desensitizing the receptors to where they don't work as effectively or they don't get activated to the same degree. So for instance, here you'd have like say an active receptor versus having something that uncouples, and so that way it actually wouldn't signal whatever kind of downstream cell process that occurs here, right? That'd be one way it can happen. Sometimes you may have endocytosis occur where we may actually internalize some of those receptors, so there's fewer that are available there on the cell surface. That could be one thing. Or in some cases, you may actually have degradation and downregulation of those receptors in total. The whole point of this is that in these cases where you have too much of a hormone around, the body doesn't like to have that big of a response, and it tries to mitigate that by decreasing the number of receptors available, or the effect that can occur when binding those receptors. Make sense? And so what would be the flip side of this? Yeah, upregulation. I would say the downregulation. There must be an upregulation, right? And so this is kind of a priming sort of effect where maybe, for instance, you have, say, low levels of a hormone around, the body is not being stimulated enough, or tissue may not be stimulated enough. It says, well, hey, I want to get more response out of this hormone. Let me try to upregulate the number of receptors I have available. So you would actually have the receptors being brought up to the cell surface, and that would allow for more of them available. You're more likely for that hormone to interact with one of those receptors and cause whatever effects you're looking for. So that is another thing you're going to see. Usually when you have either low levels of a hormone, or maybe if you have something that is blocking the effects of the hormone, that will also cause upregulation to occur. Again, all this is really being done to try to maintain that homeostasis. Okay, so getting into the specific glands. You can refer back to this slide here. We're going to go, the ones I cover in more specific detail, the ones you're more likely to see that come up on the test, so just FYI. But these are good tables to kind of refer back to seeing different types of hormones that may be present. Again, I'm not going to talk about all of these on this slide. So for instance, like we're not going to talk about atrial natriuretic peptide. However, that's like a really important one when we have patients with like congestive heart failure. But we'll cover the kind of the big ones you're going to see kind of on a routine basis here. Another slide you can kind of review on your own. All right, so first off, talking about the pituitary gland. Where's the pituitary gland? It's in the brain. Good. Where in the brain? Below the hypothalamus, right? So these are very closely interlinked between the hypothalamus and the pituitary, very closely linked, and that is good because again, you're going to see that the hypothalamus is going to have a direct effect on the pituitary, which has direct effects on secreting a lot of these different hormones that will be influencing these tissues here. Again, looking at our brain, hopefully everyone has one of these, right? I may only have a half one. I've been accused of that a few times in my life, but everyone should have one of these. Find here that you actually have the hypothalamus kind of located right here underneath the hypothalamus. It must be underneath the thalamus. There you go. And so those are going to be closely interlinked there, and then you'd actually have the pituitary right here. Notice here this is closely interlinked with like the olfactory bulb. You're going to find that the optic nerve is also going to be running through here as well. So these are all very kind of closely interlinked to one another. Also, the pineal gland is another thing we're going to be talking about as well. That's going to be really. Anyone know what the pineal gland is good for? Yeah, sleep regulation. So we'll come back and talk about that a little bit later on. If any of you guys ever end up working night shift, which my sister, she's a nurse practitioner. She started out as an ER nurse and now as a nurse practitioner. She's been doing night shift for like 10 plus years. I don't know that her sleep cycle has ever been right since doing that. And that shift work disorder is a big deal because again, if you're up all night working and you come home, the sun's out, you're going to find that you're going to have a hard time sleeping. A lot of it goes back to that pineal gland, which we'll go over a little bit later in this section. Anywho, so looking at pituitary gland, you're going to find it kind of gets divvied up into the anterior portion and then the posterior portion. It's good to know which hormones get secreted from each side of that. So again, there's only two that are going to be in the posterior side. We'll see everything else is going to come from the anterior pituitary gland. Now again, these cell signals are going to be these signals are coming from the hypothalamus, which usually the thalamus and the hypothalamus are kind of intaking all these different signals to say, hey, maybe the osmolarity is not right here, or maybe the temperature is too much, or maybe whatever is going on is going to be interfacing with the pituitary, and that's going to be influencing the type of hormones we're going to be releasing there, right? Okay, so the anterior pituitary, the majority of our hormones are going to be before communicating with kind of their target organs. And so here are the big ones we're going to be referencing back to. So for instance, with the hypothalamus, you're going to find there's kind of two levels here of communication. Normally the hypothalamus is going to be secreting some sort of trophic hormone. Something is going to be stimulating the pituitary to release another hormone that's going to be influencing the target tissue. So for instance, if I was looking for, say for instance, you're in a stress state, you're thinking about your physio test coming up a week from now, you're thinking about the test on Friday, and you're stressed out, right? So when your body's stressed like that, it's going to respond by releasing what hormone? Anyone know? cortisol, right? So how does that cortisol get signaled to be released, though, from the adrenal gland? Where that happens because the thalamus, the hypothalamus are communicating with one another. Say, hey, we're stressed out. We're going to need some cortisol around here. We need some more blood sugar. We need to start breaking down some fat. We need energy here. And so the hypothalamus will release what we call corticotropin releasing hormone. All these releasing hormones are typically coming from the hypothalamus. That will then communicate with the anterior pituitary, which will release a hormone called adrenocorticotropic hormone. That will then stimulate the adrenal gland to secrete cortisol. Okay, so notice it's a multi-step process here. That's important because when you have enough cortisol that's floating around the bloodstream, do you want this process to happen kind of unimpeded? You want to keep going? No, you don't want to have too much cortisol. So once you have enough cortisol floating around, that will then feed back and can both inhibit the anterior pituitary. It's also going to feed back and inhibit the hypothalamus. You're able to inhibit it from both steps there in order to make sure you don't have too much either CRH being released or too much ACTH. Okay, that's a normal function there. You're going to find that in disease that can be kind of go awry. In case you may have either too much or too little of these hormones being released here. So we'll cover these in more detail as we go along, but this is another good reference slide to go back to. You can kind of see where what are kind of the releasing hormones that are being released from the hypothalamus, and then what are the kind of the trophic hormones that are stimulating the actual tissues there, right? So just another slide kind of showing you what the hypothalamus, hypothalamic hormones are going to be, what the anterior pituitary is releasing, what the target organ is going to be, and then what the actual function is. Again, we're going to cover each of these individually in a second here. So looking at the hypothalamus, what it's going to be releasing, we're going to have individual hormones for things like corticotropin releasing hormone. It's going to be stimulating the adrenal gland to release things like cortisol. We're going to have thyrotropin releasing hormone, which is going to influence what do you think? The thyroid, right? Because it'll then go and influence thyroid stimulating hormone, or TSH. And again, it's good to be able to look at the abbreviations. I will typically, and I just reviewed the test, and I think in every case I went ahead and spelled out what the name is and then put it in parentheses as the abbreviation. However, you should be able to recognize these when you're looking at it. So that way, because again, when labs are reporting back values and they say TSH, you need to be able to look at a TSH and know that means, you know, thyroid stimulating hormone, right? So it's good to know these sort of abbreviations, because a lot of these are going to be tests you're ordering to determine if they're in the right range for your patient or not, right? We have things like gonadotropin releasing hormone. What do you think that affects? Now, the sexual organs primarily going to be affecting that. You also can have antagonistic hormones. So you have things like gonadotropin inhibiting hormone, right? So again, that's going to have an antagonistic effect. It's going to be inhibiting the anterior pituitary from releasing things like LH and FSH, as we're going to see in a second. We also have things like prolactin inhibiting hormone versus prolactin releasing hormone. As you might imagine, that affects prolactin. And then things like growth hormone releasing hormone, or GHRH. And then there's also going to be growth hormone inhibiting hormone. Another name for that's going to be somatostatin, right? So if you ever see SS or somatostatin, that's basically going to be growth hormone inhibiting hormone. Okay. So again, all these are going to be our hypothalamic hormones are getting released and communicating with that anterior pituitary. And then on the pituitary side, again, we're going to be looking at the anterior first. We're going to have things like adrenocorticotropic hormone. That's ACTH. That's going to be stimulating our adrenal gland to release things like cortisol. We have thyroid stimulating hormone, or TSH. Again, anytime you have a patient coming in complaining of fatigue and lack of energy and concentration, like TSH is always going to be one of the first things you're checking on your patients. You have things like follicle stimulating hormone and luteinizing hormone. These are both very important, and these are being influenced by gonadotropin releasing hormone. These are going to be influencing your sexual organs. Yes, sir.
Are the hormones released by the hypothalamus like released directly into the pituitary gland, or are they in the bloodstream as well?
They are going to be kind of more directly communicating with that. So again, you don't normally you're not checking a lot of blood levels for a lot of the hypothalamic hormones, but typically once the pituitary, once that gets the signal, it'll then release those into the bloodstream. It's a little bit more of a direct connection between the hypothalamus and the anterior pituitary. Yep. Okay. Again, these are LH and FSH are important for our sexual organs. We'll also have prolactin that gets released from there, and then growth hormone as well. And then for the posterior lobe of the pituitary glands, we're going to have antidiuretic hormone, ADH. You'll see that referred to. Another name for it is vasopressin. You ever see vasopressin? That's basically, and again, we can give that as a drug for some of our patients. We'll see what that does for us a little bit later on. But antidiuretic hormone is very important. And what do you think this does? Retains fluid, stops you from peeing, basically, just by looking at the name, right? Antidiuretic. And then there's oxytocin. We mentioned it's kind of like our love hormone. This is what kind of helps mom and baby to bond after birth. So we'll see that also has some function as well. So these two are going to be from the posterior lobe. The rest of these are going to be coming from the anterior lobe of the pituitary gland. And so right here, you can kind of see that communication between the hypothalamus directly into the posterior pituitary. This is actually going to be Again, here's the anterior side, here's the posterior side. So again, these are kind of oriented, kind of flipped to what some of the other slides were looking like. So this is actually a kind of a bloodstream connection here that's going on versus this kind of a direct sort of neuronal activation of that. So a little bit different between anterior and posterior. I'm not going to get that granular on the test that you need to know that specifically. I'd rather you know basically where each of these hormones are coming from. That's probably a good thing to know for testing purposes. In case it comes up, I'm not sure if it will or not. Maybe. Okay. All right, so looking at this, again, you can kind of see the relationship between the hypothalamic hormones versus what's being released in the pituitary. So again, we'll cover these in detail when we get to the individual organs. So just kind of reference back to this. Just know whether, what CARH, when you see that, what it's stimulating. Know what TRH is stimulating, know what's going to be causing to be released from the anterior pituitary. Those are things to know for the test. First off, looking at growth hormone, what do you think growth hormone does for us? Causes you to grow, I might imagine, right? So yes, so this is very important for a thing. Do you think it's an anabolic or catabolic hormone? It's actually an anabolic hormone, right? So if you ever see like some of these bodybuilders, some of these are actually abusing growth hormone to try to help to increase muscle production and things like that. But yes, this is definitely an anabolic sort of So looking at growth hormone, or somatotropin is another name you may see it being called. And again, for a lot of these patients, and I deal with this quite frequently with some of our pediatric patients over at Nemours, is that they're lacking these hormones themselves. We have to give them exogenous versions of it. Either, in some cases, maybe animal derived. Sometimes it's going to be like a synthetic form we've actually made. But in these cases, we have to supplement this. So again, this is something we'll give quite frequently to some of our kids who may have a pituitary deficiency and they cannot produce their own somatostatin. We may actually give that to them to help kind of stimulate production or inhibit certain things in some cases, as it turns out. I'm sorry, somatotropin in these cases, that would stimulate growth hormone production. Anyway, so what you're going to see is that, if you were to look at, say, for instance, body weight for a patient, say here's a control patient versus someone who's getting daily growth hormone, you notice here it's, they're definitely having a big impact on weight, which is usually an impact on things like organ development, muscle production, bone production, things like that. What do you think happens if you had, say, maybe unchecked amounts of growth hormone being released into the body? Yeah, so gigantism, right? I'll have a picture of that in a second. But you remember like Andre the Giant? Anyone watch that documentary on HBO recently? Excellent documentary. If you're into wrestling at all, I definitely recommend watching. Even if you're not, it's very interesting. The guy, anyway. But what would happen if I had to say a lack of growth hormone? You might see dwarfism, right? So you might see very short people related to that. So again, you can see direct effects. What happens if you have too much or too little of a lot of these hormones here? So again, the hypothalamus secretes that growth hormone releasing hormone, that's GHRH, and that's going to be affecting the anterior pituitary to secrete growth hormone. And again, this is going to be affecting, this is a very non-specific sort of hormone. It's going to affect all sorts of things. So it can affect fat metabolism, protein synthesis, effects on the bones, like effects on height and all these different things. So very, very wide ranging. And the other thing to note here is that your body continuously releasing the same amount of growth hormone or any of these hormones all the time? No, there's going to be some rhythm to it. There's going to be a circadian sort of rhythm to it where you may see kind of peaks and valleys depending on what's going on, or certain physiologic events can actually influence this as well. So for instance, when you have strenuous exercise, your body wants to do what to compensate for that? Wants to get stronger, right? So again, if I'm going and lifting weights, and all of a sudden, I have that kind of strenuous exercise stimulating that muscle, that's going to feed back and tell my brain, hey, we may need some more growth hormone. So you can actually measure these levels and see, hey, after strenuous exercise, levels go up, and then if you don't exercise, it's going to go back down. And there'll be some variations there, depending on time of day and various things like that. So you can imagine someone who had gigantism, who had too much growth hormone. This may be like with a tumor that may be secreting growth hormone. You can see in some cases, or like a pituitary tumor can sometimes result in this. Again, this is not good because you don't want too much growth hormone, because you tend to find that they have a lot of organ dysfunction that can occur over time. They can have things like heart failure develop, all kinds of problems later on in life. So again, not great to have too much of it around. And then obviously here's, anyone know this guy's name? He played R2-D2 originally. He's in Willow. Warwick Davis, a little bit of trivia there for you. But yes, he's still in a lot of the sci-fi movies nowadays, so he still gets some work. Anyway, but yeah, so again, if you had deficient in growth hormone, you can see dwarfism develop there. Okay, next up we have prolactin. What does prolactin do you think? Milk production, right? So it's going to be prolactin, lactate, milk. So you can kind of make that parallel. So PRL, you may see being abbreviated. So prolactin, we mentioned, kind of works in conjunction with the oxytocin, but prolactin itself is going to be stimulated by this PIH, this prolactin, or can be, inhibited by PIH to actually prevent lactation in some cases, or this PRH, this prolactin releasing hormones, will be stimulating that to produce new prolactin, right? There's going to be some other influences you can see here. There's lots of drugs that can actually affect this and can lead to some issues here. So one of the things to think about is, say you have a baby, and say you are breastfeeding it. We said that, prolactin helps to increase, milk production, so that way you can actually feed the baby effectively. You may find that it actually has, does your body think, do you want to get pregnant again immediately? Many of you don't have kids. You would know that, yes, you do not want to have a kid immediately after just having one. You're still breastfeeding. That's not good. So you may find that prolactin actually can inhibit ovulation. Ovulation, we'll find later on, is very, very important. That's when the egg is primed to meet with the sperm, and then you can produce a new person, right? However, when your body's in the state where it's like, I'm trying to feed this little one, I don't want to have another little one already, because then I might not have enough food for both, right? Again, think about this kind of survival instincts. You're going to see that you can have prolactin actually has an inhibitory effect on ovulation. This can be important because if you have someone who's releasing too much prolactin, even if they're not breastfeeding an infant, if they're producing too much prolactin, this can actually have anovulation, or they may actually have a hard time conceiving children. And so this is a common complaint where a lot of people go to like reproductive endocrinologists because they can't have kids. A lot of it could be related to having too much prolactin around. So again, you can see there's multiple effects you can have here, not just on breast tissue, but also within the ovaries themselves, right? So that can be a big issue. I can guarantee you, do you think this is 100% effective at preventing a secondary pregnancy? I can tell you from experience it is not. Quite unfortunate. I'm just kidding. No, my second little one's great, but she's the first one. You try so hard for it every month. You're like, it happened? It happened? You say, no, it didn't happen. And then it finally happens. You're like, yay. And the second one, you're like, kind of throwing up a lot, kind of run down. What's going on? And we go to the dollar store, get a pregnancy test, and then he comes back and says, yeah, it's positive. Oh boy. But then you're kind of happy about it. So anyway, don't rely on breastfeeding and prolactin alone. Again, hormones are fallible just like people are, okay? Anyway, I feel bad for my second one because, again, we have PEDS Day every year, and so we usually like to do a newborn exam. So I had Dr. Nicholson actually do a newborn exam on my 2-month-old at the time. So I had like 64 people like all checking her out naked, and I was like, this kid's gonna have some severe mental health issues due to me. So. Anywho, all right. So again, just know there's going to be prolactin releasing hormones, prolactin inhibiting hormone, and that will have direct effects from the hypothalamus to the pituitary, whether or not we want to secrete more prolactin, right? Having too much of that can actually inhibit ovulation, may prevent you from having a pregnancy. Having too little of it may be an issue if you're, say, for instance, trying to breastfeed, right? You may not have enough breast milk production there. You're going to find another, anyone heard of dopamine before? What does dopamine do for us? Anyone know? Yeah, kind of happy. It's that reward pathway. So if like you have like a big juicy hamburger or like you do heroin, you can activate that reward pathway. So it's a similar process, right? So I recommend the burger, not the heroin though. But dopamine is very important for that. It's also really important for movement as well. So when we talk about Parkinson's, you're going to find that dopamine is very important for that. And so dopamine actually has a big effect here as well, because if you have too much dopamine, that can actually have an inhibitory effect here and can decrease prolactin levels. What do you think prolactin might do to a male patient? Yeah, so what do you call it when you have male breast development? Gynecomastia, yeah. So it's actually one of those things you can see. And so we'll have, and again, not to turn this into a farm class, but when you have antipsychotic drugs, it can actually block dopamine. You actually see they have too much prolactin. So one of the things that guys will complain about is gynecomastia, or this breast development. Again, it's an untoward side effect of messing around with prolactin levels for these patients, right? So again, that part's not important to memorize. Just know that there's different hormonal effects that can happen here. Different neurotransmitters even can have big roles to play here. Okay. All right. And again, if you were to have, again, looking at kind of the feedback loops that are happening here, again, having that sensory input, that's kind of what's triggering the mom to say, hey, I need to produce some milk here. Having that suckling response or like a baby crying or something like that. And never watched The Office? Like Kevin, he's like, after Pam gets pregnant and she's breastfeeding, he goes up to her and he's like, wah, wah. Yeah. The same thing can happen basically with babies crying. And that stimulates the hypothalamus to then stimulate the pituitary gland. And then not only are you getting prolactin, but also oxytocin will be stimulated as well. And that helps with milk production on the prolactin side and then milk release on the oxytocin side, right? And so again, when the baby shuts up and they're eating, they're fine, then that stimulation is going to be decreased. That's a negative feedback loop. And then hopefully oxytocin and prolactin levels will go back down to whatever they were normally, right? Okay, moving on, we then have FSH and LH stands for follicle stimulating hormone and luteinizing hormone. Absolutely. And so these are very important for development of the sex organs, both in the ovaries and also in the testes for male patients. There's going to be gonadotropin inhibiting hormone. That's going to be an inhibitory hormone on the anterior pituitary that will inhibit the release of FSH and LH. And then there's going to be the more important one we run into clinically. It's going to be GnRH. That's going to be gonadotropin releasing hormone, and that's going to be secreted and it will allow for the anterior pituitary to release FSH and LH that can then stimulate either the ovaries, which is going to help to control the menstrual cycle in female patients, or it can help with testicular development, sperm production, things like that in your male patients on the testes there. And again, these are all going to be negative feedback loops. And so one of the things you'll see is that some of the major hormones that get produced in these sex organs are going to be what our effectors are that are going to feedback, inhibit the system here. So for instance, in the ovaries, the main hormones they produce are estrogen and progesterone, right? So those are the main things that are going to be forming within the ovaries there. That can feed back and inhibit both the pituitary gland and inhibit the hypothalamus, right? So again, when the body senses there's too much estrogen and progesterone around, it'll shut that whole system down. Now, has anyone heard of oral contraceptives? What's usually contained in those? Estrogen and a progesterone, right? So again, maybe not progesterone specifically, but a progestin, something that looks like a progesterone. That is the same process here, where I can actually give exogenous hormones and will activate this negative feedback loop. And if you don't have any LH and FSH being released from the pituitary, if I inhibit that by giving exogenous hormones, what do you think that's going to do to the ovaries? They never get stimulated, they never ovulate, and guess what? You don't get pregnant, right? That's one of the the key features of oral contraceptives. That's how they're working, is by activating this negative feedback loop, right? On the flip side of that, say for instance I have testosterone is going to be one of the main androgenic hormones we'll see being secreted by the testes. And that will also have a negative feedback loop. So has anyone ever heard of someone maybe abusing testosterone for nefarious purposes? Not nefarious, but maybe aesthetic purposes, right? Who might use this? Bodybuilders, right? So it may take a type of hormone that looks similar to testosterone, and again, works similarly, and that will again cause a negative feedback loop to occur here. And you know what happens to bodybuilders who take a lot of testosterone? What happens to their testicles? They shrink, right? Because again, they lack that LH and FSH to stimulate that tissue growth, right? So instead of having that hypertrophy, they're going to shrink down, and so that's one of the side effects that's known with that, right? Same process here between the oral contraceptives and giving testosterone exogenously. Same things are happening essentially. Kind of make sense? So you can understand that negative feedback loop is really, really important there. Okay. Again, just it kind of shows you kind of the same thing we're talking about here. So again, having estrogens, androgens, they can feedback, not only inhibit the hypothalamus, but they can also feedback and inhibit the anterior pituitary. So you can hit it kind of at two different levels there to stop further release of the FSH and LH. Okay, next up we have the adrenal gland. Where do the adrenal glands lie at? On top of the kidneys, right? So adrenal, so again, right around the so again, you kind of find them sitting here, perfect. And then anyone know what kind of hormones get released from the adrenal glands? Aldosterone is gonna be a good one. Anything else? Cortisol is another big one. We'll talk about epinephrine and norepinephrine. Not technically hormones, but more like neurotransmitters. I kind of refer back to more neurotransmitters, but very important aspect of the sympathetic nervous system, which we'll cover here as we go along. But basically, you're going to find that the adrenal gland is going to be consisting of an outer adrenal cortex, and then you're going to have the adrenal medulla, right? Some people say medulla, some people say medulla. I'll probably interchange between the two. They're fine, but they're kind of functioning as separate glands here, right? So again, when you think about the adrenal cortex, you want to think about that as being different than the medulla there, right? So you're going to find that the medulla is going to be secreting epinephrine and norepinephrine. Okay, so that's going to be very important. You guys know what this does to the body? Anyone? It's part of the sympathetic nervous system. It's part of the fight or flight response, right? Good. So you're going to be, and we'll cover the physiologic effects here in just a minute. But again, you're thinking about fight or flight response, thinking about that kind of like I need to run away from danger sort of response. Or like Friday morning at 8:30, 8:29, like fight or flight response is going to be keyed up to an exceptional degree, I can tell. But then when you look at the cortex, is where we're going to see that the main responses to ACTH are going to be happening here, right? So this is going to be adrenocorticotropin hormone is going to be secreted from the anterior pituitary, and that's going to be helping to stimulate the cortex of the adrenal gland. We're going to find there's kind of three main layers here, and they're going to be releasing three different types of hormones, as we'll see, and we get into more detail here in a second. So we're going to find you have the zona glomerulosa. This is where you're going to find aldosterone is going to be released from here. Again, we'll cover this in more detail and what these effects of these hormones are going to be. But the zona fasciculata is where most of your cortisol is going to be released from, and then the zona reticularis is going to have some androgens. I'm not going to cover these androgens super in depth because they're not really germane to our discussion here, but the main ones I want you to focus on are aldosterone and cortisol, and then we'll talk about the effects of epinephrine and norepi in just a few minutes here. But those are the main ones I want you to kind of focus on there, right? Again, just know that normally in the medulla, that's where we're going to be releasing your epi and norepi, and the cortex is where we're going to get your aldosterone and your epinephrine and cortisol being released from. Okay, so looking at the HPA axis here, you're going to have the corticotropin releasing hormone is going to be stimulating the anterior pituitary. That's what's being released by the hypothalamus, and that will then stimulate adrenocorticotropin, right? So it's going to be going directly to the adrenal cortex via the bloodstream, and then this is where it'll stimulate release of things like cortisol, aldosterone, and then small amounts of androgens. Again, not clinically as important as these other two, as we'll see here. We'll talk about these effects here. Now, cortisol, we can classify, I guess when you're looking at steroids, you can kind of classify them in two major categories. They're going to be our glucocorticoids and going to be our mineralocorticoids. Okay, so it's good to keep this distinction in mind. Glucocorticoids, just by the name, what do you think this does for us? Elevates glucose, absolutely. So when you think cortisol, you think you're stressed out, your blood sugar tends to rise, right? Because again, you need that blood sugar in order to provide energy so that we can run away from whatever stressor is stressing you out, right? Aldosterone is going to be considered a mineralocorticoid. Based on that name, what do you think it does? Think mineral, think, yeah, so think salt, right? So you want to think about your sodium, your potassium, affecting those minerals is also going to be affecting, as we mentioned, because wherever salt goes, you're going to find that water also wants to go along with it. It affects water balance quite significantly, right? So think mineralocorticoids, you want to think salt balance, you want to think potassium, you want to think fluid balance. With the glucocorticoids, you want to think glucose is one thing. We're going to find there's a host of other things it does as well, but those the way that I kind of keep those two distinguished in my mind from one another. Okay, make sense? Okay. So looking at aldosterone, again, this is going to be coming from the zona glomerulosa. We'll go cover this in more detail. This is going to come up in a big way when we talk about the kidneys a little bit later on. This is going to be regulating sodium and potassium. And the big thing it's going to do is it's going to be affecting blood pressure. Okay. So again, if I hold on to more salt, it's also going to mean I'm going to hold on to more water, right? Because based on osmosis, we talked about if you have a higher solute concentration, it's going to draw water to it, right? So the more salt I hold on to, the more water I hold on to. That affects blood pressure very significantly, right? We'll talk about why that is a little bit later. And then glucocorticoids or cortisol are going to find that this is going to be regulating glucose metabolism, as we kind of mentioned in the last slide here. Okay, so looking at cortisol, some of the other effects it does. Do we know anything else that cortisol does for us? Glucocorticoids. So you think stress, you think increased glucose. Good. We're going to cover all of these different things that it does in just a minute. It's okay if you don't know. We'll cover this in more detail. But anyway, so again, these are all going to be, these hormones are going to be, and you notice these, I've kind of shown a picture similar to this before. These are all very much interlinked to one another. Again, the precursor molecule is going to be cholesterol. You know where cholesterol is primarily made? And the liver is actually going to be the biggest place where cholesterol gets processed there. But this serves as a precursor and allows us to form all sorts of different types of steroids and hormones. So again, looking here, you can see that via these various steps. And again, I'm not going to make you memorize all these steps here. Just know that lots of different products come from this. So for instance, we have progesterone right here, right? We mentioned that's very important for ovulation, female reproductive cycles, very important there. We're also going to see things like cortisol get produced here. You can also see aldosterone. What do you kind of notice about the structure of all these? They look pretty similar, right? They all kind of share that same basic cholesterol structure. That's important because you're going to find there's some bleed over effect here. You're going to find, especially at higher levels, that you can have cortisol affect mineralocorticoid receptors, even though we call it a glucocorticoid. You can find that aldosterone may have some effects on glucose a little bit there. The other big thing, where I run into this more frequently, is especially with the oral contraceptives. The progesterones there, you can find that because it is so kind of high up on the kind of the cascade here, it can interact with lots of different receptors there. So one of the things you may complain about, or hear patients complain about with oral birth control, is may complain of swelling, may complain of a little bit of weight gain, some edema that forms from that. And that's because those progesterones, some of them interact with the mineralocorticoid receptor. That affects water balance, right? So again, these are things that clinically come up that may lead you to choosing maybe a different drug for your patient, one that does not interact with that receptor the same way. Okay, just an example. So again, looking at the HPA axis, we're going to see with this, normally the hypothalamus, again, if you have some non-specific stress, that'll stimulate these higher brain centers, which tells the hypothalamus to release that corticotropin releasing hormone. That then stimulates the anterior pituitary to release adrenocorticotropin. That then stimulates the adrenal cortex to increase cortisol. That should have a negative feedback loop, and that should feedback and actually inhibit both the anterior pituitary and hypothalamus, just like we saw before. Okay. Now imagine if I were to give exogenous steroids. And again, this is a common thing we do with lots of different types of patients. We'll give them steroids exogenously. What do you think it does to the system here?
Downregulates.
Well, it'll actually, sort of, yeah. So it actually will feedback and will inhibit the hypothalamus, the anterior pituitary, and so the adrenal cortex, similar to if I give a guy testosterone, I'll have testicular shrinkage. I'll have adrenal shrinkage essentially, and so you can actually have adrenal insufficiency. So one of the big things you worry about if you ever given someone steroids for a long period of time, if they come off of it kind of cold turkey, you can end up finding that their adrenal gland's not really been well developed, and you're going to find that it takes time for it to kind of kick back up, and they can undergo what we call adrenal insufficiency, and it can be potentially deadly, right? So it's one of those things where if someone's on long-term steroids, you have to make sure you taper them off quite slowly in some cases, because you don't want to you have to worry about them having that kind of rebound sort of effect there, that lack of cortisol being produced on their own. Okay, so again, anytime you're activating these negative feedback loops exogenously, you're going to be causing that tissue to be underdeveloped, because again, it doesn't have that stimulation from whatever's coming from the anterior pituitary. Works for the same for the ovaries as it is for the testes, as it is for the thyroid gland, adrenal cortex. They all kind of act the same way in that regard, right? Okay, so looking at this, again, just another example of the negative feedback loop here. We'll go to that in detail because we already kind of talked about that. Okay, so looking at the functions of cortisol, the main things we're going to see here, some of these are good positive things that are good in return in response to stress. Some of these are going to be bad things, especially when they're kind of chronically elevated. And again, I'd like to do like initial like day one blood levels of cortisol for you guys versus like their winter semester, and then where I assume it peaks, and then the following didactic summer semester the two second year guys are on right now, and you see it just kind of plummet, I'm sure, because there's so much less stress than you guys are right now. I'd love to do that study, but probably unethical, so I'm not going to do it. But some of the effects you're going to see here, certainly you'll have increased levels of blood glucose. It should rise in response to that. You're going to have protein degradation. This can be really bad if you have someone who's chronically stressed, because they have muscle wasting that occurs. And that can lead to less muscle mass. You can have less strength, less mobility. That can be a really bad thing with chronically a high cortisol level. You're going to find this stimulates lipolysis. Why do you think it would stimulate lipolysis? Yeah, because again, this helps to increase blood sugars. We know that we can use triglycerides. We can convert those over into fatty acids and glycerol to eventually get new glucose. Remember? We covered that yesterday. We also find it's going to block inflammation. So this is one of the big things why we use it for patients who are having some sort of inflammation. We'll give this to them exogenously to try to tamp that down. So think about autoimmune conditions. You think about things like asthma attacks with different things. We try to inhibit inflammation. That's good to a point, but if you inhibit too much inflammation and you suppress the immune system, because again, these are very much interlinked to one another. If I suppress that immune system, what do you think could happen? If my immune system's not working too well, then I can have potentially invasion of infection, or I can have bacteria, I can have viruses, I can have different things like that. So someone who's on, say, steroids chronically, they end up being immunosuppressed. Or someone who has high cortisol levels, maybe due to a tumor or maybe due to chronic stress, they tend to be more likely to get sick, right? Again, if you're chronically stressed, you tend to be more likely to come down with colds and things like that, because your immune system just isn't really up to snuff to where it would be normally, right? That's one thing you're going to definitely notice there. So we become immunodeficient is what we can call that, or with this immunosuppression that happens there. Other things you can find, also it tends to increase, because again, having too much blood glucose around, how does glucose get stored in the body? In the liver, so as glycogen, but what else does it get stored as? You have even too much of that. And adipose tissue is fat, right? So again, it gets converted back to fat, and so you can cause obesity. You end up getting kind of a moon face that occurs here. And you can also have kind of a buffalo-like torso. You kind of get a buffalo hump that occurs at the back of the neck. And so these are big things you can see with kind of chronically elevated cortisol levels in patients. Okay. And again, I mentioned we use this quite frequently to either suppress the immune response. Sometimes we'll do that. If you imagine if you have someone who transplanted, say, a liver into a new patient, one of the things you have to worry about is rejection of that foreign tissue by the patient. We can actually give them steroids to try to suppress that and try to make sure they don't reject the organ. And also you'll use it to try to block inflammation as well. So if you have something like asthma attack, we can block that inflammation. So lots of medical uses. You're going to see we use this for all kinds of different disease states when we get into the farm later on next semester. Just some examples. This would be someone who has Cushing's disease, who has elevated cortisol levels. Notice here they kind of had that buffalo hump that forms there, kind of this accumulation of adipose tissue. Kind of notice the moon face here that occurs. These kind of purple striae that form here. What do you call this? Here, besides a better beard than I can grow. Call it hirsutism. That's going to be the abnormal hair growth, right? Because again, this has to do with the cortisol kind of bleeding over and having some other effects on different types of tissue than what you really would expect it to. So hirsutism is a possible side effect you can see with kind of high levels of cortisol. Okay. On the other side, again, you're looking at the actual the outer edges of the cortex there. We also have aldosterone being released. Aldosterone is really, really important for salt regulation, for potassium regulation, for fluid balance. And again, we're going to find that aldosterone is going to be one of the primary things we're going to see working in the kidneys. It's going to be one of the main hormones that is going to be effective there. So aldosterone itself is going to be doing things like increasing reabsorption of sodium within the kidneys. So again, if I'm in a case where I'm saying a low sodium balance, I say hyponatremia, or there's a case where I need to try to hold on to more water, I'm going to try to hold on to more salt by using aldosterone. One of the other things you're going to find is it also increases secretion of potassium. So if you had someone who had, say maybe normal to high sodium, but they had a low potassium, what do you call low potassium? Hypokalemia. One of the things you could check is maybe they have too much aldosterone because maybe they're wasting too much potassium in the kidneys there. That's another lab that you could potentially check. But also anywhere that salt goes, water tends to follow via osmosis, as we talked about yesterday. And so if you're holding on to salt, you're definitely going to hold on to more water. So say I had too much aldosterone, that would cause me maybe to hold on to too much water, and that could lead to what? Edema, absolutely. So you can see that definitely develop these patients. So again, by holding on to that water, you're going to have increased blood volume. And have increased blood volume, that's also going to increase blood pressure, right? Because there's just have more volume there in the veins and the arteries. So what you see is when patients have aldosterone in too high of an amount, hyperaldosteronism as we call it, that can cause hypokalemia. On the flip side of that, if you actually have low levels of aldosterone or give something to block aldosterone, you can have hyperkalemia, right? Is there any problems with hyperkalemia? The dysrhythmias are going to be one of the big things you can see. So that can actually lead to all kinds of dysrhythmias that can kill your patient, right? Which again, we don't want to do. So. All right, so those are the main effects of aldosterone. Right, so again, looking at this, you see that ACTH will be stimulating the adrenal cortex. It's going to cause increased aldosterone to be released, which is going to increase reabsorption of sodium. And again, we'll get into the kidney stuff later on, so we'll go into this more in detail. But that increases sodium retention. We'll end up secreting more potassium. That increases blood volume. That increases blood pressure. And then you're going to find that's going to help to regulate our cardiovascular system to a large degree. And so later on, we're going to talk about blood pressure. We'll talk about what controls that. But when you talk about the renin-angiotensin-aldosterone system, this is going to come back into play there quite a bit, right? Because this is one of the main things that affects cardiovascular outcomes for patients, like having heart attacks and things like that, is the effects of aldosterone. So kind of keep this in the back of your mind. Example, someone who had, say, insufficient glucocorticoids like cortisol and mineralocorticoids, this would be called Addison's disease. So here's JFK. Usual things you'll see with that includes like weight loss, low blood pressure, and they actually end up developing hyperpigmentation of the skin. A lot of that's due to having too much ACTH, and we'll talk about why that is a little bit later. Hypoglycemia, salt craving, all of that. Okay, so now that I've stressed you guys out sufficiently, let's go ahead and take a 10-minute break. We'll come back and continue on. All right, so going back to talking about stress in the adrenal gland, we mentioned there's kind of two components to it with the cortex, which is where a lot of our cortisol is being produced there along with aldosterone. We also have the medulla there. It's going to be responsible for interacting with the sympathetic nervous system to release things like norepinephrine and epinephrine, right? So again, these are kind of two components here. Now, we mentioned that hormones tend to work a little bit slower than you see with things that are directly working with like the sympathetic nervous system or nervous system in general. And so you typically are going to find that while all three of these components are going to be kind of working in tandem, they do kind of similar things to one another. A little bit of difference between these three. I'm going to tend to find the epinephrine and norepi tend to have a little bit more of a fast, immediate response versus glucocorticoids. The cortisol takes a little bit longer to kick in. So a good example of this would be something like, say, an anaphylactic reaction. What's an anaphylactic reaction? Yeah, having a severe allergic reaction. Does anyone know what happens when you have an allergic reaction like that? A lot of histamine. What happens to the airway? Closes up, right? You worry about the patient losing their airway. That's probably what's going to kill them first. You also see they tend to get like hypotensive. Their blood pressure drops down because of all the histamine and things like that. So one of the things we'll do is we'll give them the first drug we give them. Anyone know what drug they take? EpiPen, right? EpiPen is one of the first things. So just like our adrenal glands probably releasing to that patient, I can give them an EpiPen. That kicks in almost immediately, right? Very fast acting versus, but we'll also end up giving them steroids like a glucocorticoid like prednisone or dexamethasone or something like that. We'll cover all those in pharm later on, but just know that we're giving them a glucocorticoid. That takes time to work though. So again, the hormones tend to work a little bit slower, maybe a few hours or so, but things like epi and norepi, those kick in almost immediately, causing an increase in blood pressure, heart rate, very, very fast acting. But looking at this general adaptation syndrome that happens here, this is kind of your general response to stress that occurs. Typically, and again, we like homeostasis. This is kind of our baseline here. You're going to see typically like during, illness or trauma or something like that, you want to have a little bit of that stress response. But again, all things in moderation. You can get to a point where you're going to find that you develop resistance over time, and then you can eventually exhaust the system essentially, right? And so we want to avoid our patients getting to this point. And you're going to find there's all kinds of litany of problems that can develop from having kind of a chronically kind of upregulated sort of adaptive response here, right? So again, we don't want to have too much stress because again, we're going to tire ourselves out at some point. So, initially you're going to find that you have this alarm reaction that's typically going to be activating those adrenal glands in the medulla first. Again, that's epi and norepi are going to be released in high amounts. Then you're going to develop, some stage of resistance. People tend to readjust in response to this. So again, if you're chronically stressed, say over the course of a 2-year period, or you're pursuing a degree, your body will develop some sort of resistance to that. You'll get kind of to a new set point, a new normal essentially, where your kind of homeostasis is essentially. At some certain point, though, again, some people may get too stressed. They have the state of exhaustion and may lead to sickness. You can lead to things like infection. It can lead to all kinds of issues, and death potentially can occur here, right? Because again, you have to have cortisol around. You have to have these things around in order for your body to function normally in regards to things like blood pressure and blood sugar and all these different things like that. Okay. So during these kind of stress responses, you're going to find the adrenal glands tend to have growth, right? You're going to have hyperplasia develop there because, again, they're having overstimulation. Usually a lot of ACTH is going to be stimulating that from the anterior pituitary. But you can also have things like decreased white blood cell production due to the sort of immunosuppressive effects of things like cortisol. But you can also have things like formation of peptic ulcers, right? Where are those at? In the stomach, right? And so again, we can find that this is important because again, if you're kind of chronically stressed, you always hear about people who develop ulcers. They're constantly like chowing down on Tums and stuff because they're always stressed out. And a lot of that has to do with the fact that this kind of chronic high levels of cortisol can have some pretty negative effects on the GI tract as well. So other things you can find here, typically you're going to find, especially in the early cases, you're going to find increases in blood pressure. So again, if they're already a hypertensive patient, they're going to be more hypertensive, increase in heart rate, cardiac output. Tend to see increases in things like cholesterol, platelets. Platelets can lead to things like clotting, which may be inappropriate. That can be an issue. Breathing rate, blood sugars tend to go up, and then a decrease in. Again, this is over the chronic period. May have decreases in things like logical thinking. Again, you've ever been so stressed out you can't even concentrate on what you're studying anymore. That can happen over time. I hope that doesn't happen to you guys. I'm sure you all do fine. But issues especially the immune system, bowel function tends to take a hit, and I'll show you what that looks like in a second. Reproductive function, because again, if you're really stressed out, is your body thinking about trying to reproduce? Probably not, right? You want to get over whatever that stressful period is, and then hopefully get to a point where you can, your body's more like, okay, now we're ready to reproduce at this point. I always told my wife, with our first one, it did take us a little while to get pregnant, about a year or so, but every single month, it was just her stress level just kept going up and up and up and up, and I was like, oh, that cortisol is not good for you. And of course, what's the best way to get someone to relax? Tell them to relax, right? Just chill out, it'll happen. That's not help. It's not helping the situation. It's, okay, well. You want to be a good listener in those cases, just so you know, always be a good partner. But anyway, yeah, that was definitely one of those things that was really kind of probably being a negative influence on the whole reproductive cycle. Versus our second one, we weren't even trying, and then boom, it just happened like that. So again, bodies are complicated. Is all I'm trying to say there.
Are all those reversible?
The babies, no, they're permanent. It's a great setup. No, okay. 18 years at least.
Are any of those going to become permanent?
Permanent, you may find chronic issues that can develop. So for instance, people have chronic hypertension. They tend to have chronic issues known like the coronary vessels. We know they have increased risk for things like heart attack and heart disease. And some that may not be reversible, but for the most part, especially for more kind of short acute term sort of stresses, yes, this is absolutely reversible. It may take some time. However, once those cortisol levels get back down to normal, once you're not secreting a ton of epi and norepi, those tend to come back down to normal levels essentially, right? But again, it just depends on, because especially hypertensive patients, normally you have receptors that can detect pressure, called baroreceptors. Over time, with really chronically hypertensive patients, those reset to where maybe 120/80 is normal for most healthy individuals, but maybe now 140/90 is now their normal. And when you get below that, their body reacts to that and says, oh, well, we got to get back to the normal blood pressure, even though their normal is abnormal, essentially, right? So again, there's going to be some cases where it may have a slow reversal, but it tends to go back to normal levels, right? The shorter period it is, the easier it is to reverse those effects there. But so anyway, so looking at kind of this response here again, here's the initial alarm response. It's that initial response from the sympathetic nervous system and all that. The stressor is going to release things like increased, corticotropin releasing hormone. You're also going to have adrenocorticotropin is going to be increased in release here, right? So it's going to go up. That stimulates what? ACTH stimulates the adrenal glands to release Cortisol, good. So these are things you want to keep these relationships in mind. So again, you're going to find an increase in glucocorticoids like cortisol, right? That's our primary one we're going to see there. Again, inflammation response tends to go down, right? So you're going to see a decrease in inflammation, which is good because if you have like an injury or something, you don't want to necessarily have all that pain and swelling associated with that. So that can be a good thing in limited cases. That typically see blood glucose go up. However, over the long term, you're going to find decreases in an immune response, more risk for infection. You're going to have a decreased resistance to disease, and that can lead to all sorts of issues, namely death being the primary one we're trying to avoid there. Now, on the flip side of that, when you're looking at more of the sympathetic activity there, and again, later on in the class, we'll cover sympathetic nervous system in greater detail, but we're going to find that increased norepi and epi, those are going to have direct effects on things like increasing blood pressure by causing vasoconstriction. They're going to increase cardiac output by increasing heart rate and increasing the squeeze of the heart, essentially, and so blood pressure goes up, right? So over time, as you have that continued increased vasoconstriction, increased blood pressure, that's where we see hypertension develop, and that can lead to things like cardiac failure, renal failure, and again, can lead to death eventually. So you can see where we want to keep these things limited, try to limit as much stress as we can. It's the primary reason why I came to work here, because I like teaching. Like it's a very stress-free kind of job for me personally. Some people hate teaching, but where I was working before full-time, didn't like it so much. I was stressed out all the time. Now I come back here and it's like, oh, this is much nicer. So again, always try to find the job where you're at least stressed is the thing I would like to tell you. When you got to work for like 30, 40 years, you want to be as little stressed as possible. Anywho, all right, so looking at other non-specific stress things that happen here, typically you're going to find increased blood sugar, increased blood pressure, breathing rate, metabolic rate tends to be increased here. The long-term effects are going to find a lot of issues with the kidneys are going to occur there because you're going to be holding on to more fluid. You're going to have fluid retention happen with that. Again, you're going to have muscle wasting because they're trying to convert all those proteins into glucose. You're going to have lipolysis that occurs. You're going to be trying to have that converted into glucose as well. So again, these are all things you're going to see with more kind of chronic stress issues. Okay. Just another picture kind of showing the same thing we were looking at before there. So you can kind of refer back to that. And when I say atherogenic dyslipidemia, what does that mean? You know, causes atherosclerosis. You know what that means? Yeah, you're developing plaques and things like that in the coronary vessels, right? That's what leads to heart attacks and whatnot, right? So that's what we don't want to have occur with that. So again, having high stress levels and things like that, you have increased cholesterol levels, that can lead to things like atherosclerosis. We'll go into more detail on that later on, but just know that can be one of the other big things we worry about. Anyone know what time or what time and day is the most common to have a heart attack? Usually Monday mornings is most common because most people are getting up to work and they're usually stressed out about their crappy job, and then all the extra cortisol just knocks them over and they have a heart attack, right? All that epi, norepi kind of tips that over. So if you see people having a heart attack, it tends to be Monday mornings. Not always, but again, that seems to be a little bit more common. Anywho, okay, so looking at this as well, you know, with chronic stress leads to increased risk of that illness, as we mentioned. We talked about a whole litany of things that can happen there. Again, heart disease, hypertension, increased blood sugar leads to diabetes, all those different issues there. And again, you can also find, like, you know, increased cortisol levels chronically, that we know that increases blood sugar levels. That also is going to lead to increased levels of what? Well, increased blood sugar leads to increased levels of what being released? Insulin, right? So we know that. But again, over time, by overstimulating those insulin receptors, what do you think happens? Downregulation, right? You develop insulin resistance that occurs there, and that's what's leading to things like type 2 diabetes. So insulin resistance is another big key component to that. So again, we have to limit that as much as we can for these patients. Okay, looking at the GI tract, so one of the big important things that helps to maintain the gastric barrier, because we mentioned the stomach is very, very acidic, around a pH of 2, left in direct contact with the gastric tissue, it would burn right through it. It would cause holes to form all over. The thing that protects us from that are going to be this kind of mucosal barrier that we can form. And one of the big things that helps us to do that is going to be prostaglandins. We kind of mentioned prostaglandins in one of the first lectures there. Very important because it helps to maintain that mucosal barrier. If I inhibit that with chronic stress, and one of the things you'll see is that prostaglandins, when you put an anti-inflammatory on board like cortisol, that tends to decrease prostaglandin synthesis. And there's more to it than that, but we'll talk about that as in pharm and other classes. But just know that high cortisol levels decreases prostaglandin synthesis, which decreases that gastric barrier. So that's why you can see this kind of erosive gastritis that can form, because now that stomach acid and again all those enzymes that are meant to chew up proteins start to chew up that gastric tissue there, and can eventually lead to perforations, bleeding, which can be life-threatening and severe enough bleeds there. So again, chronic stress. That's why you always often think about them having stress-induced ulcers, things like that. We worry about this pretty frequently. And especially in critically ill patients. So if you ever work like in ICU or intensive care unit, a lot of our patients tend to get really critically stressed due to sepsis and other disease states. And so they tend to not produce a lot of their own prostaglandins because their cortisol levels are through the roof. And so we have to worry about them developing stress ulcers as well. So again, it can happen, regular people who are just stressed all the time, or it can happen in certain medical conditions additionally. So lots of different reasons for this to happen. Okay, so moving on, talking about the thyroid glands, I guess. So again, it's going to be located right here on the neck. It's going to be basically two sizes. Anyone know what other endocrine gland lies on the thyroid? Yeah, the parathyroid is always going to be there. We'll talk about that later. That also has a very distinct function that is not really related to the thyroid function. We'll see why that is in a second. Anywho, so the big thing is you're going to find that is that TSH. And again, thyrotropin releasing hormones, what gets released by the hypothalamus onto the anterior pituitary, that is going to stimulate release of TSH, thyroid stimulating hormone, and this is going to be stimulating the thyroid to release T4 and T3, right? T4 is otherwise known as thyroxine, but T4 and T3 are very important to kind of keep the relationship between those, and you need to have both of those. Okay, we'll talk about why that is in a second. Now, what ion is necessary in order to produce thyroid hormone? You have to have iodine. That's why you see in a lot of developing countries when they don't have iodine, like enriched foods, they tend to develop a lot of goiters and things like that. We'll talk about why that is in a second, but basically you need iodine around in order to form T4 and T3. So we're going to see that typically your body's producing a lot more T4 than T3. However, T3 is a more active form. It's a little bit more necessary in order to perform the normal metabolic functions that thyroid hormone does. So normally T4 has to be converted over to T3. So even though in your body you're normally circulating around more T4 than T3, once it gets converted, that's when it's more metabolically active. So that's the important thing to know there. And again, you don't need a ton of iodine. About 1 milligram a week is all it's needed for necessary function. Keep in mind, though, that too little iodine can obviously lead to deficiencies in T4 and T3. Too much iodine can also inhibit the thyroid gland as well, right? So you don't want too much, you want too little, you want to have just the right amount, right? So what you're going to find, as I mentioned, is the majority of it is going to be floating around as T4. If you guys ever heard of the drug that we give for hypothyroidism? Synthroid, anyone ever heard of that? That's actually T4. We're just giving you synthetic T4 essentially that the body then converts over to T3. But again, this is the active form. So another name for that is thyroxine. The T3, the other name for that is triiodothyronine. You just need to know T4 and T3 is fine by my purposes. But anyway, there's another form called reverse T3, but it's not physiologically active, so we don't really care about that one. But really, T3 is the main active form we care about. Again, you can store some in the thyroid gland, but typically you don't have to store a ton of it at any given time. It normally just can be released and usually be carried around the blood on certain types of carrier proteins and whatnot. But again, a lot of times, like you have patients come in, they're complaining of fatigue and lack of energy and all these things like that. Usually, the first thing you're going to check is going to be the thyroid function, right? So if you're coming to alter mental status, anything like that, check a thyroid function. And normally, what we're doing is we're actually checking for their TSH. Again, it's thyroid stimulating hormone that's being released by the anterior pituitary, perfect, and then free T4. When I say free T4, anyone know what that means? As opposed to like the premium T4 you had to pay for. No, free T4 just means it is not bound to serum proteins, right? So again, we'll talk about this with drugs as well, but usually you're going to have things like albumin and different serum proteins that can carry molecules around. And so one of the big things we're going to see is things like thyroglobulin are going to be responsible for carrying around T4. However, when things are bound to serum proteins, they don't really interact with the tissues that well because they're bound up. So you want to measure what's actually free and what's actually floating around by itself because that is going to be more physiologically active. So normally we measure a free T4 and a TSH, and that can give us an idea of kind of what their thyroid function is doing, right? So again, if someone's coming in, they're complaining of being cold all the time, they have no energy and all this, and I check a free T4 and it's low, that's a pretty easy sign. I can tell that, okay, well, yeah, they probably don't have enough thyroid hormone in order to meet their metabolic demands. And then you can fix that. You can try giving them drugs to replace that. Or there may be another issue. And we'll talk about where you can kind of test these different points here. Because what is TSH really telling me? If someone has hypothyroidism, what do you think their TSH level is going to be? Low, high, normal? So, right, so if you think about it by looking back at the negative feedback loop, if my thyroid is not producing enough T4, and so my T4 levels are low, none of that's feeding back to inhibit the anterior pituitary. So what does that mean there? It's going to be releasing more TSH because it never has the shutoff signal to say, hey, stop producing this. So if you have someone who has hypothyroidism, typically they have a high TSH because, again, that negative feedback loop is not being inhibited, and their T4 levels are low. And if I were to supplement that, if I were to give them Synthroid and they were to come back, say, 8 weeks later, I would hopefully see their TSH levels are starting to drop back down to normal, and their free T4 may be normal as well, hopefully, right? Or I mean, you adjust the dose or something. But those are the things we're kind of looking for. That way we can tell if it's going to be a pituitary issue or if it's going to be a thyroid issue. So, for instance, if I came back and the free T4 was low and the TSH was low, what might that tell me? Either pituitary is not secreting it, or what else could it be? The TRH isn't really being secreted enough to stimulate it, right? So there's something else going on at that point. So you can kind of figure out whether it's going to be kind of a primary issue with the organ right, the thyroid gland itself, or it could be a secondary issue with the pituitary, or it could be a kind of a tertiary issue with the hypothalamus. And that's what's important to try to determine. Again, for most people, it's going to be an issue with the thyroid, so you'll see that TSH be high. But if it's low, along with the low T4, then you know something else is going on, something more complicated than just that. Okay. And a problem can happen on any step of the process there, and that can happen with any of these endocrine systems we're talking about today. So having high T4 levels, you'd call that what? Hyperthyroidism, right? So again, you're going to expect them to be kind of hypermetabolic in a lot of cases, and so you're going to see things like increased metabolic activity. Their temperatures usually low, high, normal, usually higher, or they tend to run hot. You're going to find things like increased carbohydrate, fat metabolism. Can stimulate growth, especially in children. Increased GI motility, which may manifest as what? Diarrhea might be one of the big things. If you have someone developing diarrhea and they have all these other kind of litany of symptoms, that could clue you into things like hyperthyroidism. They tend to be kind of like anxious and worried. They seem to be like they were kind of really stressed out, and they develop things like hyperreflexia and fine muscle tremors, things like that, right? So these are all things you're going to evaluate your patient. But okay, well, you have these different signs and symptoms. It makes me think you have hyperthyroidism. Let me go ahead and check your levels and see what's going on. In those cases, if you had someone who had, say, a high T4 level, what would you expect their TSH level to be? It'd be low in that case, right? Because again, I'm having that T4 feeding back, hopefully inhibiting that TSH. If it's still high, that may be something else. It could be something indicative of like maybe a tumor that's secreting TSH or something like that. But those are things you're going to be trying to assess there, whether it's an issue with the thyroid gland or it's an issue with something else along the pathway. Other things, just increased metabolism overall, some more cellular respiration happening there. Usually it'll be, tachypneic, breathing faster. This can, obviously have scales of gray here, but they can lead to all the way to things like thyrotoxicosis, which is very kind of severe toxicity here, or thyroid storm, which can happen. They tend to be very hypertensive, tachycardic, tachypneic. They're very metabolically overactive, and you need to try to tamp that down as quick as you can, otherwise it can lead to some long-term issues. Usually they're going to have decreased ability to sleep because they'll be tired, but they can't really sleep because, again, they're so anxious and they really just have too much energy to go to sleep there. And then you can have issues where you have decreased bleeding in the menstrual cycle. Again, it may shut down ovulation and things like that. You can also develop what we call, anyone know this is termed? It's exothalamus, and that can occur with Graves' disease, which is actually an autoimmune condition where we're having antibodies that are actually stimulating the TSH receptors, actually stimulate the thyroid hormone production. So you can see things like increased heart rate, hyperreflexia, increased blood pressure. You see weight loss associated with this because, again, they're kind of burning through their energy so quickly they're running out of energy stores. All of that, right? So that'd be one case, one manifestation of hyperthyroidism. So again, here's an example where you can see where the different problems may lie, whether it's going to be in the hypothalamus, the pituitary, or it's actually going to be the gland itself. So let's say, for instance, the thyroid is abnormal. In these cases, you'd have T4, T3 being high. You would expect what? TSH should be low, because again, that negative feedback loop is still intact, and the TRH should be low as well. Okay. Now, if the issue is the anterior pituitary, you would expect the T4 and T3 to be high, because we know they have hyperthyroidism. The TSH would be high as well, but the TRH should be low, because that one component of the negative feedback loop is still intact at that point, right? So TRH would be low in this situation because there's too much TSH and T4, T3 feeding back and inhibiting that. Or if the issue, say the hypothalamus is secreting too much TRH, you expect all of these to be high at that point, right? So again, by looking at these different levels, you can kind of figure out, okay, where's the actual issue? Is it the pituitary, is it the hypothalamus, or is it the thyroid gland itself? Okay. Yes, ma'am.
Is it usually like a tumor that causes it to secrete more?
I would expect to see a tumor, or that's kind of the primary thing I think of necessarily, but there probably are some other causes as well. But again, if you talk to like an endocrinologist, and again, that's always my caveat with like these things, is that like I have my perspective from the pharmacist's perspective, also from like emergency medicine, toxicology, pediatrics, like that's my thing. Endocrinology, like I don't do it every single day, so you may talk to someone who's an endocrinologist, just like I may talk to someone who's a dietitian, and they know way more about me in the field than that, right? The whole point here is that you guys like ready to practice as like a family practice PA, right? So again, you may not need all that detail, but if you go to talk to someone who deals with thyroid issues every single day, they may have a much more detailed answer and they have a different perspective on it. They may either conflict with mine or may back it up. Just depends on what the case may be. Okay, but yeah, I normally think of tumors though as being what may be secreting that. Yeah. Okay, if we had low levels of thyroid gland or thyroid hormone, what would we call that? Hypothyroidism, absolutely good. So again, typically think of fatigue, decreased metabolic activity. Usually their weight is usually doing what? It usually goes up because they're in a kind of a low metabolic sort of state. Usually their temperature's running low, right? So have kind of cold intolerance associated with that. Then we have hyporeflexia, decreased muscle activity, decreased GI motility, which can manifest as Constipation, right? So again, the opposite of GI hypermotility, which can cause diarrhea, would be constipation there. Good. Usually kind of a depressed sort of mood, may kind of, and oftentimes if you have patients presenting and you think they have depression, major depressive disorder, one of the other things you're also going to check for is their thyroid gland, because again, that could be one of those things where if you fix the thyroid, all of a sudden their depressive symptoms go away, and then you never actually have to treat them for depression in the first place. So again, it could be multifactorial, it could be one or the other, it just depends on the patient. Usually hypersomnolence, meaning they're sleeping too much. I wish I had that problem, but and then usually again you still see some menstrual irregularities, usually increased bleeding in this case, impotence, decreased libido, all kinds of problems with that. Now, if you were to look at the HPA axis again, what you would expect to see if the thyroid was abnormal, say for instance I had a decreased amount of say iodine, or the thyroid gland was incapable of producing T4 or T3, you expect this to be low, but TSH and TRH you'd expect to be high in these cases, right? Because the negative feedback loop is never being activated at that point, right? And because that TSH is so high, what do you think what effect do you think it has on the thyroid gland? Usually that's when you develop goiter, right? They have the hyperplasia of the thyroid tissue, and that's usually going to be in case of their hypothyroid, and they have too much TSH stimulating that because that negative feedback loop is missing there, right? So goiter is one of those kind of things. I have some pictures here in a second I'll show you. Now, if the issue is with the anterior pituitary, you'd expect TSH to be low because that's not being produced there, which would result in T4 and T3 being low. However, TRH would expect to be high because, again, that negative feedback loop is not being activated, still stimulating the anterior pituitary, or trying to at least. And then if it's a hypothalamic issue, all of these would end up being low in that case there. So it kind of makes sense, and again, you can kind of go back and look at the levels and say, okay, well, where do I think the problem lies? And it may influence your management pretty dramatically, right? Okay, so again, here's an example of someone, kind of a mild goiter, another picture of someone has even a bigger one, but again, it's usually due to low levels of T4 or T3, causing you'd have too much of TSH, and that usually is going to be stimulating that thyroid gland to try to increase production. But again, if you're missing like a precursor like iodine, it doesn't matter how much TSH you have, you're just going to end up increasing that tissue, but not producing really any T4 or T3. Here's another picture of a pretty significant one. You can kind of see there. You might imagine we can have some like respiratory issues potentially, especially with all that weight there being on the neck. A lot of issues you can see with that. Okay. So we covered the negative feedback loop, but just know that this is kind of what's this can apply to any of these hormones we were talking about here. Again, the negative feedback loop is king here, and then any problems along the pathway you can kind of identify based on levels of these hormones if you can measure them. Okay, calcitonin is going to actually be released within the thyroid gland as well. This is going to be in the C cells, these parafollicular cells of the thyroid. This is actually stimulated by high levels of calcium. Okay, so we call that hypercalcemia, right? So that'd be high levels of calcium in the blood there. And so this is going to help to function. So you're going to think of calcitonin as being the opposite side of the coin compared to parathyroid hormone. They kind of have antagonistic effects to one another. Just like glucagon and insulin are antagonistic, calcitonin and PTH are going to be pretty antagonistic to one another. So typically we have high calcium levels. Calcitonin is going to end up being released, and it's going to have several different features here. One of the things it's going to do is to have an effect on the bone. It's going to have an effect on the intestine. It's going to have an effect on the kidneys. Okay, what does the bone matter with calcium? That's where it's all stored, right? So it's the main repository of calcium. How about the GI tract? That's where we absorb calcium. Good. And then how about the kidneys? That's how we filter it and we can get rid of it potentially, right? So again, you're going to find the different hormones, whether it's PTH or calcitonin, can have an effect on whether or not you're going to be reabsorbing calcium or you're secreting it to eliminate within the kidneys. So what you would find with calcitonin, because I have high calcium levels, my response is going to be to lower calcium levels, right? So again, those cells are detecting there's too much calcium around. I'm going to try to lower it by releasing calcitonin. So I'm going to inhibit the dissolution of calcium from the bone. Remember, there's osteoclasts and there's osteoblasts. Which one degrade bone? The clasts are going to be degrading the bone. This is going to put an inhibitory effect on those, so that way you're going to be laying down more calcium than you are pulling out of it, essentially, right? So that's one effect you're going to see. It's also going to stimulate excretion of calcium from the kidneys. So you're going to have extra calcium being released in the urine, and then it's going to inhibit intestinal absorption of calcium. So even though you may be drinking a ton of milk or something full of calcium, it will inhibit the amount that can actually be taken in from the GI tract and will just be eliminated through the feces. Okay, those are the three main effects you're going to see with calcitonin, and hopefully it's going to bring the calcium back down to normal levels. And then once you're normal, then it can activate that negative feedback loop and decrease the amount of calcitonin being released. Okay. Okay, so looking at the posterior pituitary gland. As mentioned, there's two hormones that come from here. Anyone remember what they were? ADH and oxytocin. So you can see here it's going to be this kind of direct kind of neuronal sort of connection here. They're going to stimulate release of ADH and oxytocin. Notice that you don't have the same kind of multi-level sort of approach as you did between the hypothalamus and the anterior pituitary. It's not like you're releasing ADH, releasing hormones. It's nothing like that. It's produced up here in the hypothalamus, but then directly released within the posterior pituitary. So really, it's just going to have ADH, which gets just released from there. It has direct effects. There's not really kind of a middleman sort of approach there, like you see with the anterior pituitary. So that's kind of the difference between the anterior and the posterior pituitary. So what you find is oxytocin very good for stimulating childbirth. I mentioned this gets upregulated, especially when like a child's about to be born and their head's pushing on the cervix. That actually will stimulate that positive feedback loop. Remember we talked about that, how that kind of has a kind of a positive effect on itself to kind of increase release of a hormone, increase the whatever's going on, whether it be blood clotting or the child being born. But it also stimulates that milk letdown. It's working with prolactin in those cases there. Antidiuretic hormone, very, very important for blood pressure management, very important for regulating thirst centers, and very important for regulating water handling within the kidneys. How much we're going to hold on to, how much we're going to get rid of potentially. Okay. Has anyone ever, you guys I'm sure have never experienced ethanol in any way, shape, or form, I'm sure, but has anyone ever heard of the term popping the seal or breaking the seal? What does that usually mean?
Break.
So, some people pop, some people break, it just depends. But so you break the seal, what does that mean? So you're having a couple beers, and then you go to the bathroom, right? And then all of a sudden, you just pee like crazy. You're like, I gotta go to the bathroom every 5 minutes or so. Does anyone know why that is? Yeah, so ethanol actually inhibits production of ADH. It actually inhibits the release of that. So antidiuretic hormone, if I have less of it, guess what? Now I'm going to be in a diuretic, more prone state, right? So again, if you're curious, you can wow your friends with your physiologic knowledge there. But just know that, hey, that beer, the reason why I have to go to the bathroom so much is because it inhibits ADH release. But I digress. Anyway, that's an important point, though, because again, if I have too much ADH, that means I'm also going to be peeing less, and I'm going to be holding on to more water, right? And it's going to have a direct effect on things like blood pressure, etc. We're also going to find ADH is going to be really good as a vasoconstrictor and also raise up blood pressure. And in fact, when you have someone who is in the ICU and they're very sick and they're very hypotensive, this might be one of the things we give them via IV in order to get their blood pressure back up. So here, a vasopressin. It's another name for ADH, and we'll give that via continuous infusion to try to get their blood pressure back up. So mentioned oxytocin here. It's kind of that love hormone that kind of helps with that bonding between, say, mother and child. We can also give this one to women who are in labor to try to help stimulate them to have the labor faster. So again, for both my children, my wife got oxytocin via IV, try to help stimulate things along. But also gets stimulated by things like suckling by the infant, and will help with that milk letdown and work in conjunction with prolactin to help with feeding the baby. Those are primary effects there. And again, that positive feedback loop, we talked about that, how they get in the head against the cervix will increase release of oxytocin. That will then stimulate uterine contractions to push that head against the cervix even more. So that positive feedback loop occurs. Once the baby's out, then that pressure is gone, and that will shut down oxytocin stimulation there. Antidiuretic hormone, again, this is going to be stimulated by either low blood volume or if you have low blood pressure. So this can either be detected by things like the left atria or also baroreceptors. I mentioned those are detecting blood pressure essentially, and so that can be one stimulation there. It'll also be stimulated by an increase in blood osmolality. When I say increased blood osmolality, what do you think that means? Blood is too dilute, too concentrated? Too concentrated, right? So again, if you're in a case where you're too concentrated, and I say have concomitant low blood volume, I want to try to get that diluted out by holding on to more water. I either want to intake more water or I want to hold on to more water, essentially, right? So that's going to be one of the big things that ADH is going to be seen doing. Remember I talked about those head trauma patients who had too much ADH being released and their thirst was going crazy. They just wanted to break out of the hospital room under any circumstances to get some Gatorade or to drink anything that had some water in it. But it also helps promote water retention in the kidneys. We'll talk about that much more in detail when we get to the renal section later on, but just know that's a very important aspect there. But so again, good for regulating blood osmolality, regulating water balance, and can also work as a vasoconstrictor. Okay. And again, if I have too much vasoconstriction, that leads to hypertension, which is not a good thing in a lot of patients. So again, regulating this is important in a lot of cases. Okay, so again, looking at, say, these osmoreceptors are going to be in the hypothalamus. This is what triggers ADH release directly from the posterior pituitary. That'll also stimulate the thirst response. They're going to try to drink water to try to get their osmolality back to the correct set point, right? So again, usually like a 280 to 290 sort of range there. And then as it comes back down, say, more closer to 300, whatever the range you're looking at happens to be, that'll then lead to that homeostasis point, right? So once it comes back under control, ADH release will then go down. Okay. Also, it can help with things like permeability of water in the kidneys, so that's how it's going to help to hold on to more water there. We'll talk about that later on, but that also can help to raise our blood pressure and then dilute out the blood to get the osmolality back into check, essentially. Okay. Any questions on those two? All right. Next up, the parathyroid, which are located where? No, the essentially. And so generally, they're going to have kind of 4 of them. They're going to be implanted here, as you can see. And these are going to be responsible for releasing parathyroid hormone, absolutely. So sometimes we have to keep these things pretty straight. But again, this is going to be the flip side of calcitonin. This is going to be released in response to what? If calcitonin was in response to hypercalcemia, parathyroid hormone gets released in response to hypocalcemia, right? And again, the same thing is going to be affecting the bones, affecting the kidneys, and affecting the GI tract. Again, if hypocalcemia, you want to raise those calcium levels up, so it's going to increase activity of what cell on the bone? Osteoclast, perfect. It's going to increase reabsorption of calcium from the bones. So you're going to have that start to come out of there. You're going to have the kidneys start to reabsorb more calcium as it gets filtered, and you're going to have the GI tract start to do what? Increased absorption of calcium from the GI tract. Anyone know what other hormones really important for? I know you know, but anyone know what other hormone really is important for helping to regulate this with parathyroid hormone? Vitamin C. Not C. Close. D. Vitamin D. Right. Vitamin D is super, super important because that kind of works in tandem. It's one of those things kind of more permissive and more synergistic with PTH in order to help increase that calcium reabsorption. And in fact, if you can have a ton of parathyroid hormone, not having enough vitamin D, and still run into issues where you're going to be hypocalcemic. So they need to really work together in a lot of cases. And know where you get vitamin D from? You get some of it from the sun. Where else? Kinds of foods that have high in vitamin D, but it's one of these fat-soluble vitamins, so you can find it in different varying food sources. But the big thing is that whenever you're developing it, like you're getting it from food or you're getting it from the sun, that's not the actual activated form. And one of the big problems you run into with patients who have renal disease or kidney disease is they can't actually activate the vitamin D themselves. And so that leads them to develop hypocalcemia because they don't have enough vitamin D to help regulate that. And they also end up developing hyperparathyroidism. So their parathyroid is too overactive and they're releasing too much PTH. And what ends up happening, they can actually cause too much osteoclast activity and it degrades down the bone, leading to things like osteomalacia and then potentially osteoporosis, right? Because I'm weakening the bone because I'm getting rid of all that calcium. So vitamin D, parathyroid hormone is super, super important. We're talking about kidney disease, which we'll get into in detail later on. Okay, so again, looking at this, most of the calcium is being stored up in the bones there. Again, there should be a balance between resorption and deposition of calcium there. If you don't have that, if you have too much resorption, that's what leads to things like osteoporosis. The kidneys, again, a lot of it gets filtered. Most of it should be reabsorbed, but we can affect that based on calcitonin levels and PTH. And then also in the GI tract, this is where we're going to see that we don't absorb all the calcium that comes through, but we try to absorb what we can, depending on what our calcium levels are doing. Again, vitamin D and PTH will have a direct effect on that. Again, this is a negative feedback loop, so once your calcium levels start to rise up and they get into the right range, that should feed back to the parathyroid and start to shut it down and say, hey, okay, we have enough calcium around, we don't need to release anymore. You can start to decrease production there, and that helps to maintain that balance between your calcium levels and the bone and everywhere else. Okay, again, just another picture kind of showing the same thing there. You get another picture showing the same thing. I don't know why I put so many in here, but anywho. But again, looking at the flip side between PTH and calcitonin, again, calcitonin is going to be released in response to what? Hypercalcemia. PTH is going to be released in response to hypocalcemia. Again, they're working antagonistically to one another. However, PTH and vitamin D tend to be working synergistically or kind of permissively to one another. Okay. Next, we have the pancreas. So anyone know what the pancreas releases? Insulin and glucagon. Those are the two big endocrine functions that it has. What are the exocrine functions? What does it release there? Lipase. Bicarbonate. Some bicarbonate. Any other enzymes? Like trypsin gets released from there. It helps them metabolize proteins. Also, amylase will be released from there as well. And actually, when you're working someone up for pancreatitis, amylase and lipase are two of the big things you're going to measure there for those patients, right? So again, those are big exocrine functions because they get released into the GI tract. However, we're going to talk about that in GI later on. And some glucagon are the big things we're focused on. We're already experts because we've already talked about it like 12 different times already. So you guys shouldn't need too much reiteration here. However, endocrine cells within the pancreas are going to include the alpha cells, which have the glucagon, and then the beta cells, which are going to be releasing the insulin, right? And so a type 1 diabetic patient might have insufficiency of which type of cells? Usually beta cells, right? Usually it's an autoimmune condition that has led to destruction of those beta cells, right? It's either a relative or absolute deficiency of insulin being released from those cells there. Again, these are working antagonistically to one another. You can see a picture here how the pancreas is going to be working as an exocrine gland, kind of secreting right into the small intestine, but also being able to release into the bloodstream its endocrine function as well. All right, so insulin itself is a protein. Again, that's why we usually have to give it via injection. Can't give it orally because proteins do not do well in the GI tract, as it turns out. Just like the hamburger you eat gets broken down, insulin does the same thing essentially. However, it gets released from those beta cells within the pancreas. And notice here it comes out as a kind of a prohormone. It actually has to be cleaved into the actual active form you can see here. Now it's interesting, we'll get into this in the farm later on, but by changing little tiny amino acid sequences here, you can get all kinds of different types of insulin. You get some that last for like 24 hours, and get some that last for only maybe 30 minutes, 45 minutes, by changing the amino acid sequences. It's kind of cool how we can monkey with that. They're not from monkeys, they're actually synthetically formed. Does anyone know where we used to get insulin from? Pigs and you should do beef too, yeah. So cows with the two sources. Now we don't have to do that anymore. We have recombinant forms that we can make, which is good because people have a lot of allergies whenever you're injecting animal proteins into people. Anywho, so looking at this, you can see that by having having high blood sugar, especially after you eat things like that, you're going to be stimulating insulin to be released. That is then going to cause glucose to be stored in the liver as glycogen. It's also going to be stimulating adipose tissue to store excess glucose as fat. It's going to be working on all these things, especially getting glucose into the cells where they're needed, especially skeletal muscle and things like that. And so we'll look at a picture of how that works here in just a second. So essentially what you're looking at is that insulin is going to bind on this receptor here at the cell surface. And again, normally glucose cannot cross that lipid bilayer. It's not able to go by on its own, which is good because we want to regulate how much glucose gets into our cells. So by insulin coming and activating this insulin receptor, it's going to cause downstream effects to where we actually have this GLUT transporter gets sent out onto the cell surface there. Normally this would not be expressed on the cell surface until you have insulin come along and then stimulate it to be increased, right? And again, our body's always releasing some amount of insulin. Never completely shut down. So you always have some glucose transporters there. However, we can regulate it based on how much we need, based on blood sugar, etc. So again, you'll always have some glucose transporters, but we can upregulate that based on the insulin effect you're going to see there. Okay. Again, depending on which type of tissue you're dealing with, you may be different types of glucose transporters. I don't want you to get that granular. Just know that this is what insulin is doing, causing glucose transporters to be sent up to the cell surface to where they can then cause that facilitated diffusion where it sends glucose through, essentially, right? Again, usually insulin is going to have a positive effect on producing glycogen, a positive effect on forming new fatty acids by turning glucose into those, and then have a negative effect on that conversion of triglycerides to fatty acids, right? Now, however, if I had a patient who's completely deficient in insulin, we said that can develop into what? So they have, say, low blood sugar, or they have low insulin, they can't get sugar into the cells. What does the cells have to rely on for energy? It's going to start to form ketone bodies because it's going to be oxidizing those fatty acids, and that's where you can get diabetic ketoacidosis. That's how that develops there. So it's good that normally insulin is going to have a negative effect here to inhibit triglyceride breakdown into those fatty acids, essentially. Okay, just another picture kind of showing the same thing, how the insulin receptor here, when we talk about this in pharma, it's going to be called a tyrosine kinase receptor, as we'll see a little bit later on, but it's going to stimulate translocation by signaling downstream for these glucose transporters to be located onto the cell surface. That allows glucose to come into the cell via that facilitated diffusion. And then glucagon obviously being antagonistic, so that is going to be triggered in response to hypoglycemia. If low blood sugar levels is going to stimulate the liver to do what? Glycogenolysis, right? Glycogenolysis, and then gluconeogenesis, absolutely right. So we're going to break down glycogen because we need that blood sugar. It's going to turn it back into glucose, and then it can circulate around the bloodstream to whatever tissues it's needed at. Again, most patients you'll find, especially like type 1 diabetic patients, when they're like a new diagnosis, they'll oftentimes get a prescription for glucagon because we know they have a risk for hypoglycemia because they're injecting their own insulin. Sometimes they don't respond well to it. We'll give them a dose of glucagon so that way they can inject it into themselves and get their blood sugars back up potentially. So that's a common thing you'll see with type 1 diabetic patients. Okay. Other things you may see is this can also stimulate gluconeogenesis, as we mentioned, that conversion of non-carbohydrates into glucose, so again, fatty acids and proteins potentially, and then we'll stimulate lipolysis so it can break down those fatty tissues and get those triglycerides free so we can start to interact with those and make glucose out of them. Okay. Again, just know they're antagonistic, so again, if insulin's high, glucagon should be low. And if glucagon's high, insulin should be low. You're going to find that patients, like especially type 2 diabetics who are chronically hyperglycemic, they tend to have a lot of issues where their glucagon levels do not regulate very well. And so they may actually have high glucagon levels despite not really needing it, despite their blood sugar already being high. And that's one of the big problems we run into. We have actual certain drugs we can do to combat that. But just know they're antagonistic to one another. Should have, if you have high glucagon, should have low insulin, and vice versa. Okay, just another picture kind of showing a similar thing here. Remember, it's just that kind of seesaw sort of pattern here. Again, if it goes in one direction or the other, it can run into some issues, either hyperglycemia or hypoglycemia. Okay, what time do I have? A couple minutes. All right, so the kidneys. Hormones get released by the kidneys. Erythropoietin, which does what for us? Yep, absolutely. So where do we stimulate red blood cell production? In the bone. Which bones in particular? Usually flat bones, yeah. So you're going to think things like the sternum is going to be one big place. Usually here and like the ends of some of the long bones. So you can see in the hip and the vertebrae, places like that are going to be the main sites of red blood cell production. And this is another big problem because we run into issues where, like, especially chronic kidney disease patients, they actually have a deficiency of erythropoietin. They can't produce their own. And so what do you think that could lead to? Yeah, anemia, right? Because again, they have low red blood cell count, so it's going to be anemia because they don't have the erythropoietin to kind of stimulate that function there. So one of the things you'll commonly see kidney patients on who are anemic, will actually give them a kind of recombinant erythropoietin to try to supplement that to try to get their hematocrit and hemoglobin back up into a normal range there, or somewhat of a normal range. But because they do not have that stimulation themselves, the bones can still produce it. It's just they don't have the hormone there to actually stimulate itself. So it's a big problem in chronic kidney disease patients. We mentioned pineal glands is good for what? Yeah, for melatonin production and so again, this is going to be again kind of separate from the pituitary, but again back here, and you're going to find that it's secreting melatonin. I'm sure most of you have probably heard of someone taking melatonin exogenously or taking it themselves. Again, they take it to help regulate their sleep essentially, right? And normally you should stimulate melatonin production when what happens? When it gets dark or the sun goes down, and then it should usually decrease in production when the sun comes back up, right? Or things are bright. This is why you run into a lot of patients who have issues going to sleep at night, and what are they usually doing when they go to sleep? Like their phone on max white brightness, like right here, and it's like, well, no wonder, because like your melatonin production is probably all screwed up because their pineal gland thinks it's still daytime, right? That's why sleep hygiene, super important thing to educate patients on. Like, okay, use the bedroom for sleep and sex only. Don't have a bunch of big white screens. Like, activate the yellow filter mode on your phone. Most phones have that nowadays. Try to cut down on that kind of really bright, harsh light because it can screw up with that. And then you also run into a lot of medical professionals who have shift work disorder because they're usually working overnight. And again, they're up when it's dark outside and they're trying to sleep when it's light outside. And you can see why that can lead to a lot of sleep issues with those patients. Especially bad for those that go on for a couple nights and they come off, and then they have like a week where they're up during the daytime. I mean, they just get completely screwy on their sleep schedules there. Fortunately, I've never had to do that, but I've worked a few overnights and it just gets weird. Like, you're just like, I don't even, what day is it anymore? I don't even know. But anyway, yeah, but this also gets regulated by the hypothalamus because, again, they are pretty closely linked there. And you're going to find that this is going to be regulated also by the eyes as well, right? Because, again, you're going to have melanopsin that's going to be found in these ganglion cells of the retina, and that's what's going to be kind of stimulating that pineal gland because that's detecting whether it's day or night. It kind of, it shouldn't have like a really negative effect on production of melatonin. It may have a kind of a moderate decrease there because, again, if I'm supplying extra melatonin, I've never heard of anyone having like really bad rebound insomnia coming off of melatonin, but it's a potential risk, I suppose. But yeah, that's why it can be a very helpful adjunct if they're maybe not be producing enough of their own. Take some exogenous stuff and try to help them kind of get that sleep cycle set a little bit. But you can also see that this can be pretty well affected by things like the time of year. So for instance, if you have people who are living in certain locales where it's like nighttime for like months out of the year, or like during now, and the daytime is usually a lot longer than it would be in the winter time, that can all affect these patients in their melatonin production there. And we have certain drugs that can actually help to try to affect this, either by giving melatonin or affecting this in other ways, other pathways, which we'll talk about again later on in Pharm. Okay. Again, usually daytime should inhibit melatonin production. Nighttime should be stimulating production. And again, that's why you have that kind of natural wake up. If you get the opportunity, which you probably won't for the next few years, I guess probably the rest of your career, just to sleep in, and just like allow the nice daytime just to wake you up naturally, and the singing birds and all of that. I haven't experienced that in a while, but if it ever happens again, that's the daytime, basically that sun starting to inhibit melatonin production and kind of waking up naturally. Okay, next to the finish all this in one go is perfect. And the thymus is going to be responsible for secreting thymopoietin, and it's going to be responsible for white blood cell production. We're going to come back to this later on when we talk about the immune system more in depth, but just know that's the hormone that helps to stimulate that. And it's going to be right here in the thymus, located around the sternum. All right, that's it for endocrine. Any questions? The whirlwind tour of your endocrine glands. Again, you'll cover this in more detail in like CMS when you start to get into actual pathophysiology and different disease states and whatnot. Those are kind of the main things. Those are the main normal functions you're going to see with these organs. Any questions so far? Okay, if not, I will go see you guys tomorrow for a rounding course of pharm.